Hi, I'm Steve Niemczyk. I'm a board-certified endodontist practicing in the suburbs of Philadelphia. I've seen a lot of remarkable changes in the profession in the last 33 years, some very profound and elegant developments within the specialty. But there is one thing that remains as constant as death and taxes, and that is the fact that we have cases that will not resolve to our satisfaction despite our best efforts at trying to achieve that goal. That's going to be the topic for our discussion today, so let's get started. Before we begin the presentation, I would just like to address a semantic: treatment failure versus persistence of disease. Our medical colleagues have a good handle on this, and they perform revision surgeries and procedures to improve the outcomes of their therapies. Treatment failure semantically implies that we've done something wrong or we've done something incompletely. But we can have cases that will not resolve despite the best efforts at our cleaning, shaping, and disinfection. What are the causes of these failures? Number one is intraradicular infections. Small lateral canals that may be left at the very tips of the roots that we're working on. Very difficult to dislodge, very difficult to disinfect, and almost impossible in certain canal configurations. We can also have a persistent periapical area, harboring bacteria that we have known statistically to be very difficult to eradicate and eliminate. 3, foreign body reactions. Overextensions of the filling material in and of themselves can give rise to irritations, manifesting themselves as small cysts, or areas that may elaborate around the material in its effort to encapsulate it. And 4, a true cyst that may have nothing to do with the present root canal therapy, or it may have been a leftover pathology from the previous treatment. Let's take a look at this. This is called a sinus tract, or some people may know it as a fistula. The correct version is sinus tract. This is a gift from the endodontic gods when you see this, because this will now allow you to trace back to the origin of the infection. As you can see in this slide, we have a gutta percha tracing, but instead of the first molar, where the sinus tract is appearing on the surface of the gingival tissues, it is tracing back to the second molar, the true cause of this recurrent infection. Makes one wonder if the treatment that was rendered on the first molar, not only the non-surgical treatment, but also the surgical treatment, was also rendered in presence of the sinus tract that was not traced. One of the most common reasons for post-endodontic infections are missed canals. Most of my practice is retreatment, and I will tell you about 75% of the cases that I see are a matter of finding these canals, threading them, and treating basically the splinter that has been left in the finger that you did not remove. This tissue and the subsequent bacteria in it are going to give rise to areas and discomfort to the patient. In this particular case, by one endodontist, he was able to access, using the microscope and various armamentarium that we have specialized for this particular procedure, and we have found the second canal, the MB2, one of the most common canals that is missed. We have something in the profession called overextended but underfilled, and it almost sounds like a contradiction in terms. However, if you had a cork that may just lay in the surface of the bottle, but it does not seal the bottle, this is now overextended, but it certainly is underfilled. It is not sealing the case. And that is one of the objectives of our therapy, is sealing the root canal space that we have just cleaned very nicely. In this particular case, we can see that there's an overextension of the distal root. The reason for the material being pushed out is probably the obturative material is undersized, and it is not sealing the circumference of the shape that they have created. We also see at the mesial root a grossly undersized obturation as a result of perhaps a lack of shaping and also lack of enlargement of the both mesiobuccal and mesiolingual canals. Here's the correction. Notice in the distal canal the size and the breadth, especially at the coronal aspect. It's not only important to make sure that we clean the apical, but the length of the canal, including the middle and coronal thirds. Also notice in the distal the termination of the filling material. This is evidence that we have good seal circumferentially at the distal orifice. More dramatic is at the mesial. Notice the difference in size from the previous radiograph. The size of the obturative material is a direct reflection of the shaping protocols that have been employed here. And again, terminating where we would like to see it, ideally a ½ millimeter from the major foramen. One of the most common etiologies, as we have seen, is a missed canal. But it doesn't have to be the whole canal that's missed. We can have portions of the canal that we have not insinuated an instrument into or have had the benefit of irrigation dissolving the tissue that's there. As you can see in this radiograph, the mesial root is grossly undersized in terms of its shaping and cleaning. The distal root is somewhat better, but still there are portions of the canal space, as evidenced by the obturative material, that have not been cleaned and have not been filled by the gutta percha. In terms of poorly obturated and sealed teeth, these three teeth are emblematic of so many different problems that we see. In the premolar, we have an underextension, a gross underextension of the instrumentation. There is a portion about 3 to 4 millimeters of the apical portion of this root that has not been cleaned, as evidenced by the obturative material. In the second molar, you can see that the operator may have encountered some difficulty in insinuating these instruments in these very tortuous canals. We don't see the obturative material going to the apex or even closely towards the apex. The first molar has not been treated, but it is symptomatic, as evidenced by the periapical pathology that we see on the palatal root. All three of these teeth require treatment, but only two require the retreatment. Initial therapy on the root canal and the first molar, we would expect a good response to this. However, in the retreatment, we know statistically that because of the difficulties in harvesting this material, gaining access to the original canal spaces, disinfecting them to a certain degree, and filling them as completely as possible presents more of a challenge than we see in a case that has not been intervened before. This radiograph shows the results of the instrumentation and retreatment in these three particular teeth. Notice the flowing form, the extent of the material, the sizes that have been appropriate for these particular teeth. And it's just a matter of time before these teeth on a 6-month recall will give us evidence of healing because we have removed the principal etiology. Coronal leakage plays a very large part in our therapy. Now here, appropriate shaping may or may not have been done, but that is secondary to the difficulty that we see in the presentation of the caries subjacent to the crown. We have a very large post in the distal, and this will give rise, if it is in communication with the caries, this will allow us to have communication with the obturative material in the distal. The same holds true for the mesial. And you can see we have a periapical area on the mesial root, also extending up into the furcation, which gives one cause for concern. Is this truly a periapical problem, or do we have now a situation where the caries has invaded the furcation underneath the crown and perhaps rendered this tooth non-restorable? Clinical examination will be the only thing that will tell us this. Perforations are not too common. However, they are in certain instances preventable, and this has to do with the shaping protocols in the coronal aspect of the root. Knowing the anatomy of the root will give rise to a better approach in terms of our flaring protocols, but suffice to say that if we use an instrument that is too large and too aggressive, we run the risk of straightening the curvature of these roots to the point where we establish a communication between the canal space and the bone that surrounds the tooth itself. From the intracanal space, to seal a perforation is very difficult. Requires a microscope and some very elegant instruments to deliver the material to the site of the perforation, to seal it well, and then perhaps even an auxiliary procedure surgically to augment the seal after a small period of time of reevaluation. Prevention is 9/10 of the cure in this particular situation. All of which leads us to this. In all of the instances we see, bacteria is the root of all of the problems that we've just presented. This is what causes the breakdown periapically. This is what is going to cause the patient's symptoms. And this is what we are hoping to eradicate either during the initial therapy or during our retreatment. A very common cause, and probably more common than we have seen in the previous 20 years, is fractured roots. Now, whether we're getting better at diagnosing this particular etiology, or in fact the presenting public is becoming more stressed and now starting to fracture these roots, we don't know. However, it is a very elusive etiology, and diagnosing fractured roots can become a very delicate operation involving some very precise periodontal probing, perhaps some very elegant radiography, but by and large we are relying on the patient's symptoms for these particular presentations. Suffice to say that a fractured root is like a highway for bacteria. It may be very small and minuscule to our direct observation, but to a bacteria, this is a direct route to the periapical area. Perforations, they're like separated instruments. If you do enough root canal, chances are you are going to commit this. The cases that we're treating nowadays are much more involved and much more difficult, especially posteriorly. The canals may be dystrophically obliterated, or what we have classically called calcified. And gaining access to these dystrophically obliterated canals sometimes causes us to dig where we don't want to dig in our search for these spaces. When that happens, we have now a communication between the access of the root canal space and the periodontium on the surface of the root. It is most important that we seal this perforation at the same time as the appointment, or certainly within 24 hours of committing the perforation. We know statistically that if we do this, ingrowth of granulation tissue, which is responsible in large part for most of these perforation failures, will not occur. If you do not have mineral trioxide aggregate, or more commonly known as MTA, to seal the perforation, please seal it with some sort of temporary restoration, either IRM, cavit, perhaps some glass ionomer. What the most important part of this is making sure that you seal this perforation before the granulation tissue ingrowth. Keep in mind that if you do not seal it with MTA, any other sealing material will not suffice, and it is a temporary measure at best. So you need to return to revise the MTA fill, or refer to an endodontist where it can be done under the microscope and under appropriate isolation using the appropriate instruments. Gaining access to these retreated canals can be very difficult, and one of the most common causes for failure to do so is a ledge canal. As you can see in this radiograph, we have periapical areas distal and mesial, with perhaps underextension of the fill itself. What was the reason for the underfilling? Perhaps the instrument lodged in a dilaceration. Perhaps it had difficulty negotiating the canal space apical to where the obturative material is evident. Whatever the reason is, we have to now negotiate past this blockage and to the periapical area to satisfy the protocols that we have set forth. Shaping and cleaning down to the apical terminus, and then filling these spaces as completely as possible. The ultimate goal does not stop with filling the root canal spaces. The ultimate goal now is restoring the tooth with a correct coronal seal and with appropriate function for that tooth's place in the arch. The ultimate goal of all our therapies, whether initial treatment or in retreatment, doesn't end when we fill the root canals with whatever obturative material we're using. The ultimate goal is to be able to restore this tooth back into function, to seal the access that we have created within the tooth, and allow this tooth now to function in its correct place of the arch. As we have said, endodontic therapy is not complete until the tooth is restored to function. As we can see from this flow chart, the quality of the cleaning and shaping of the canal system is at the head of this flow chart. Going down the steps, the ultimate result that we will achieve depends on the skill and the experience of the clinician who's performing the procedure. It has a great deal to do with the materials that we are introducing in there, not only as the final obturative material, but also the materials that we are cleaning with, hypochlorite and other materials. We are also ultimately dependent on our interpretation of our follow-up recall radiographs and the angulations that we may employ to see the different aspects of the canal and its reevaluation of its healing or not healing. Finally, we need to have the appropriate restoration placed in a timely manner as soon as possible so that we can prevent reinfection of the canal system and a retreatment situation. It's a well-known fact that if we don't have a coronal seal over the obturative material, we know that it's just a matter of time before the root canal fillings that we have placed are going to leak. This pair of radiographs illustrates the point of coronal leakage. On the left, we have a radiograph of canine that has been treated fairly well. The only thing that is absent from the equation is the coronal seal. Whether it was in place to begin with, or now it has been lost, or it was never placed following the therapy, we don't know. What we do know is that after a small period of time and exposed to the oral environment, we can have percolation and migration of salivary products, bacteria, apically to the root canal system, and in a very short time, contamination of the apical third of the root, if not the periapical area, could be expected. One of the studies that has been done by Magura illustrates that after a period of 3 months, if there is no temporary restoration to prevent this contamination from the saliva, then you could expect the case to be reinfected again, necessitating retreatment. Is there a best way to obturate these teeth? Here's a radiograph showing a canine that has been treated. Take note of the size of the obturation and also the extent. We can see that the gutta percha cone is extending in the periapical area, in and of itself an irritation. The size of the obturation gives us concern in terms of the size of the instrumentation and therefore the cleaning that has been affected on this particular tooth. But most importantly, notice there is no restoration in the coronal aspect. The post will do very little to prevent any kind of ingrowth or percolation of fluids, and the lack of the permanent restoration on the coronal aspect of this tooth will lead to the demise and the reinfection of this case. Here's another view showing the extent of the periapical area, the extent of the post, and also the space between the obturative material and the post itself. If the post has been placed without the tooth being isolated, we can also expect salivary products to have been inoculated into the space and then sealed in this space with this particular post. Retreatment of this case involves harvesting the post, which may or may not be difficult depending on what it's been sealed with, recapturing the material not only in the canal itself, but also harvesting it from the periapical area, cleaning and shaping using various instruments down to the terminus that have been described by our protocols, and then cleaning this with hyperchlorite and other fluids so that our obturative material not only fits to the proper extent, but also to the proper size and the volume to fill the canal and seal it well. Here we can see in this radiograph, the post space has been placed while the canal was under isolation, which is the best way to do it, and it has been sealed with a temporary restoration. This tooth is now ready to receive the post and the coronal buildup and subsequent crown. Now take a look at this one. The thing that comes to mind, is this an endodontic failure because of the initial treatment? Or is this now a failure because of the angulation of the post and the non-sealing around the ferrule of the root surface? To say this was an endodontic failure would be a misnomer. The restoration does not adequately supply the support that the tooth needs, and the fact that it is now subject to coronal leakage will lead to the retreatment of this tooth. Next, we'll address 3 concepts: whether the tooth can be restored, how we isolate it during the restoration, and the timing for the placement of the permanent restoration following our therapy. It is a well-known axiom that all restorations and caries need to be removed prior to endodontic therapy. Take a look at the slide in the upper right-hand corner. We can see gross caries that extends into the chamber and possibly beyond. So we need to remove this material prior to any intervention and introduction of our instruments into the canal spaces, because then we will be effectively inoculating these spaces and recontaminating the tooth. We also want to make sure that we remove all the restorations, because this can hide caries and hide material that we are effectively re-inoculating these spaces with also. Take a look at the picture in the lower right-hand side. Here we have an access that has now become recontaminated with material that either the patient has eaten or that is just present in the oral environment. We can see what appears to be a foodstuff in the access itself. If this is the case, and this is an interim tooth treatment visit, we have to consider this tooth now reinfected and reverse our protocols back to the initial steps. Fractures, one of the most elusive things to diagnose. We find fracture cases at least once a week, and they can be very challenging to divine where the fracture is and the extent of the fracture below the gingival tissues. We use various methods to do this. Under high magnification, we can stain these particular teeth, looking for these very small, fine lines emanating usually at the transitional lines of the tooth. We can also use transillumination, and those of you that are familiar with that concept, the dentin and enamel will function much like a fiber optic cable. If you break the fiber optic cable, the transmission of the light terminates where the break is, and this is what we will see. If we had, for example, the transilluminator coming from the facial surface of this particular tooth and illuminated towards the palatal aspect, where the fracture line would terminate the degree of illumination, and the palatal aspect of the tooth would become darkened. We know that these fractures are a chronic irritant, and most of the patients that will present with these fractures early on complain of periodontal symptoms. That is to say, biting, pain on release of the bite, and also localized edema subjacent to where the fracture line is. An important concern is whether or not the tooth can be restored following our therapy. Take a good look at this radiograph. Can we do root canal on this tooth? From a procedural standpoint, it's possible, but from a restorative standpoint, there are several factors here that are not going to lend themselves well to the ultimate success of this particular case. We have gross caries that are evident in the coronal aspect of the tooth and possibly extending through the furcation and down in the canal systems themselves. We also have a fair degree of bone loss in the furcation itself. So in the final restoration of this tooth, we are not only going to have to initiate restorative therapy, but quite possibly adjunct periodontal therapy to return this tooth to good health. An important consideration in our caries removal and evaluation of the restorability of the tooth is biologic width. That is the width between the eventual margin of the restoration that we're placing on this tooth following endodontic therapy and the level of the alveolar bone. We know that we need at least 3 millimeters between the margin and the alveolar bone, and at least 1 millimeter between the junctional epithelium that forms the attachment on the root surface and the margin of the eventual restoration. We cannot violate these biologic widths because the patient will respond with a painful episode. Here you can see that the crown lengthening has been done to reestablish the biologic width. This is done by very discreet removal of bone during periodontal surgery. And we can see at the mesial aspect of this tooth, the crown margin now extends far enough away to allow good resolution of the interradicular area, allow the patient to clean it well, and also satisfy the requirements that we have in terms of the cell survival and the biology of the area. Once we have done our pre-treatment evaluation and we decide that the tooth can in fact be restored, then we need to isolate it. We have to prevent any salivary contamination from within the access and down the canals by extension. Otherwise, the therapy that we're rendering is not going to be considered a surgically clean procedure. Proper isolation involves placement of a rubber dam and sealing the perimeter of the rubber dam so it is a fluid tight seal. This small video will illustrate the sealing process around this premolar. After application of the rubber dam clamp and reflection of the rubber dam material in the interdental area, we are now flowing a material that will seal the buccal and palatal aspects of this particular tooth. There are various materials that can be used. One is something called Cool Dam, which is being used here as a light cured material. There are many materials that you can use, and perhaps if you do a fair amount of cosmetic procedures in your office using a light that is intended for bleaching, the material that you use to block the rubber dam prior to the bleaching procedure and application of the fluids is ideal for this particular application. Let's follow this isolation from pre-endodontics to the point where we can begin our instrumentation. As you can see from the middle radiograph, we have a distal restorative material in this DO box that not only has an overhang but also has caries subjacent to it as a recurrent effect. We can also see various parts of the tooth that have defective restorations, as evidenced from the picture in the extreme left-hand side, the staining from beneath the amalgam giving a gray cast to the enamel part of the tooth. All of these materials are going to have to be removed prior to our intervention with our endodontic instruments. And it is a sequence of events, removing the distal and mesial boxes, removing all the existing restorations, amalgam and otherwise, getting back to sound tooth structure and assuring us that we do not have any kind of recurrent caries that could possibly contaminate our instruments as they are introduced into the case. Once we have removed all the caries, we will now restore with a composite material, in this particular case, a light cured material that will now seal the areas that we have excavated. We have left room for the access, have blocked that off so that we don't fill that in. And then the final access preparation is shown in the picture on the far right. The radiograph in the upper right-hand corner demonstrates not only a much more cleaner appearance to the restorations that are present in the tooth, but we have also now removed the overhang from the distal aspect, enhancing the recovery of the soft tissues in that particular area. This is a rather interesting and unique adaptation for an orthodontic band. Here we have teeth that have been either decayed or ground down to the gingival margin, making isolation, if not difficult, almost impossible. Adaptations of an orthodontic band around these teeth will allow us to use a temporary material such as IRM to build up inside these teeth, creating a post, in effect, that we can clamp to. Once we have the tooth isolated, it is a small matter now to re-access through the temporary restorative material, stabilized by the orthodontic band, and the band will be left in place until the final treatment has been rendered. Up to this point, we have addressed what we've been doing inside the canal spaces themselves in terms of the cleaning, shaping, and sealing. Now it's time to consider what we do following the root canal therapy. And I could tell you there's nothing more frustrating than to see a tooth on recall with the same temporary that I put in 9 months previously. Aside from that fact, we know that if the treated tooth has not been restored within 3 months and the canal system has been exposed to salivary contaminants for 3 months or greater, that tooth is essentially contaminated and needs to be retreated. Why you would not restore this in a timely manner is very interesting. You've spent so much time cleaning these teeth, shaping the canals, filling them as best as you can. The logical end is to seal this with the permanent restoration. It would be like you having a house, having all sorts of very exotic things done to the interior of the house, all sorts of marble and whatever kind of accoutrement you want, but then failing to put the roof on the house. You wouldn't do that, so why are you doing it with the root canal treated tooth? These restorations, if they are temporaries, are going to have a tendency to break down in the margins, so they will not seal. And like I said, the coronal leakage can happen very, very quickly. We know from the literature that these teeth that have been endodontically treated need to have post-restoration coverage. The degree of coverage is based on the tooth location. Posterior teeth are normally restored with full coverage crowns, either porcelain fused to metal or full ceramic, because this is where most of our grinding and chewing occurs. This is also true for anterior teeth that have restorations prior to the endodontic therapy. However, if you have an anterior tooth that does not have a restoration in place prior to therapy, a simple composite or other material bonded to the access will suffice. We also know from the literature, having provided full cuspal coverage and sealing of this tooth will allow for long-term success. Looking at full cuspal coverage, we know this investigator set forth that posterior teeth need to have the working cusps overlaid to prevent fracture. Failing to do so resulted in failure of the restoration and subsequent contamination of the root canal material underneath. Aquilio and Kaplan in 2002 found that the restorability and the survivability of these teeth was 6 times greater if you overlaid these full cusps and protected them from subsequent fracture. Are endodontically treated teeth more brittle? It's an old wives' tale, and it was finally addressed by these 2 investigators in 1992. They looked at the biologic properties between teeth that had been endodontically treated on one side of the arch and teeth that were essentially not treated on the opposite side. And they found that there were no statistic differences between the integrity of these teeth and their propensity to fracture. What they did find was that these teeth were more fragile based upon the amount of tooth structure that was remaining behind. So if you have extensive caries, if we have extensive restorations, all of these things now will contribute to loss of tooth structure, which then in turn contributes to loss of integrity and loss of support for the tooth itself. In the previous sections, we have been addressing post-endodontic restorations as an intracoronal or just a crown-supported restoration. Well, what if the tooth needs a post? How are we going to go about placing this? To what extent and to what degree? These are the topics that we will now be covering. How to use a post, when and why, the importance of the ferrule, space considerations, and the types. Before we get into the whys and wherefores of posts, let me just address an urban legend. I can't tell you how many general dentists actually still believe that a post will reinforce a tooth and lend strength to it. They're probably drawing on their exposure to a reinforced concrete slab where the mesh is incorporated into the concrete and serves to hold the concrete together. But if you look at some of the old slabs on some of these sidewalks, you will see a fair degree of crazing or cracking. Now the segments don't separate because they are joined by the mesh. We don't enjoy the same benefit. And in fact, Trope showed in his investigations that posts actually weaken the tooth, not lending any sort of structural integrity at all. So basically, the bottom line is here, don't use a post unless you absolutely are forced to. What guides us into whether or not we're going to be using a post? Well, if we keep in mind that the sole purpose of the post is to retain the core in a tooth that has had significant loss of coronal structure, then examination of the tooth following our treatment will allow us to make that determination fairly easily. In anterior teeth, where we have a very conservative access preparation and there are no other restorations present, then a post is probably contraindicated in this particular instance. However, in posterior teeth, where we've lost extensive amount of tooth structure and we have nothing to allow the crown to anchor to versus a core, if the core is not present by natural tooth structure, then we have to augment that artificially with a buildup anchored by a core within one of the canals. If the tooth has a removable partial denture, these teeth are subject to much more stresses, and according to this investigator, warrants placement of a post to allow for that structural integrity to be maintained. Hood and Dwyer in 1982 looked at how much tooth structure is actually required to lend this integrity, and they determined 1 to 2 millimeters of coronal structure was more important than any of the post materials that were in use. This 1 to 2 millimeters of remaining tooth structure following our therapy is known as the ferrule. It is not inclusive of the core material, so it's important to keep that in mind in your assessment. This 1 to 2 millimeters of natural tooth structure is what has to remain for the tooth to be strong enough to support the coronal restorations. Keep in mind that the ferrule does not include the margin of the restoration. That is a separate measurement and needs to be taken into account when we're talking about biologic width and also the restorability of this tooth. In this particular instance, you see a radiograph where a post has sheared off. Careful examination of the coronal aspect of this tooth reveals that coronal to the finish line, we had less than 1 millimeter of ferrule remaining behind. This tooth would probably have been better served by a minor periodontal procedure, crown lengthening, and extending the length of the ferrule and then subsequent placement of the post. In these die models, you can see the ferrule represented by the pink die stone. The gold-colored areas of the die would represent the core material that has been placed on this molar to support the final restoration. Again, the core material is not figured into the ferrule effect. That effect relies totally on natural tooth structure and needs to be 1 to 2 millimeters minimum. In this diagram, we can see the core represented as a gray, cone-shaped material anchored by a post placed inside the tooth. You can see the ferrule effect just below the core material and above where the butt joint is for the crown preparation. So we've determined that we need to place a post in this tooth. Begs the question, how much are we going to take out and how much are we going to leave behind in terms of gutta percha? This is a very controversial subject, and depending on who you ask, it can either be a very, very small amount or a very large amount to be left behind. Goodacre and Engel in 2008 investigated this, and what they came up with was 4 to 5 millimeters of remaining gutta percha in the apical extent of the tooth. And if you think about this from a histologic standpoint, that's actually a very good determination. We know from the micro-CT studies that most of the ramifications, lateral canals, fins, what have you, are in the apical 3 millimeters of the tooth. So if we leave 5 millimeters remaining in the apical portion of the canal that we're going to place the post in, we can be reasonably assured that we will maintain the seal in this area without compromising exposure to these small ramifications. As you can see in this radiograph, a very small amount of gutta percha remains. That point notwithstanding, the post that has been selected and placed in this tooth is rather large. Also a consideration, because if the post is fairly large, the stresses induced on the root itself will be magnified, and this could lead to failure and fracture of the root system. So once again, we will want to leave about 4 to 5 millimeters. In a case like this, if there was failure that occurred and the post could not be removed, the patient would have to be subjected to a surgical procedure to correct the lack of seal. Looking at the considerations and how much we remove and how we're removing it, let's keep in mind that the landmark that we're looking for is the minor constriction. Here we have a tooth that has undergone apical surgery, and we are removing gutta percha. The radiographic apex and the placement of the root end filling, or the retrograde filling that's here, are dissimilar in length. So in our determination of how deep we're going to go, we're not going to go just to the apical extent of what the 4 to 5 millimeters. We may actually have to lengthen that and establish our 4 to 5 millimeter length predicated on the location of the retrograde filling, not the radiographic extent of the root itself. We're not only concerned with the depth of the removal of the gutta percha and the extent of the post, but we also have to take into consideration curvature of the root system and how thick or thin these roots actually are. So take, for example, this radiograph. If this root was instead curved towards the distal, we would not be able to reach the same extent, and we would have to tailor our depth of penetration of the drill predicated on the degree of curvature and also the location of the curvature. So in our determination of placing the post, we also now have to make a clinical judgment about where the curvatures are and tailor that depth of penetration to stop short of those curvatures. In terms of thin or thick roots, please keep in mind that we need to have at least 1 to 2 millimeters of remaining tooth structure surrounding the post that we are going to be placing. One of the most popular ways to create a post space is using Gates-Glidden drills. This diagram illustrates the relative dimensions of the 6 different drills. But according to the literature, this may not be the best way to prepare these spaces. We know that following root canal therapy, the canal dimensions change dramatically. And in using a Gates-Glidden size 4 resulted in much more incidences of perforations on the inside curvature of these teeth. So these investigators determined that if you're going to use a Gates-Glidden drill, using a Gates-Glidden larger than a size 3 was probably imprudent in most cases. Evidence of perforation radiographically results in not only furcation breakdown, but extension of this breakdown apically because the root canal filling material has become contaminated. There may or may not be a sinus tract that is in place, and very often these teeth are sensitive to biting pressures because of the impact of the perforation site on the alveolar bone. The instruments that you see on the right-hand side are devices that we use to test biting and sensitivity very discreetly. One of them is a tooth sleuth. Placing this on various cuffs on the crown itself will serve to very rudimentarily locate where the perforation may be. If the posts do not fit properly, if they are too large or they are forced into place, they will create fractures. Here we have a case that you have seen previously. Post space has been created appropriately. The canal space has been sealed with a temporary restoration. So far, all is good. However, look at the placement of this post in this bridge as a bridge abutment. You can see that the post is angled off to one side. There is a gap that remains at the margin. We also see space between the post and the remaining gutta percha. All of these things will lead to a refractory failure, the most prominent of which is the off angle of the post. This will create undue stress on the root and lead to very probably an ultimate fracture of the root itself. If they don't fit properly, if they are angled incorrectly, if in fact they have been created and create a perforation in and of themselves during the post preparation, these are all considerations that figure into a restorative failure. Ultimately, it becomes an endodontic failure, even though the etiology for the occurrence is not endodontic in nature. In terms of what kind of posts we're going to be using, there has been a trend away from active style posts, which would be the screw posts or anything that is gaining some sort of mechanical advantage within the canal system itself. We are now placing, by and large, passive posts that are parallel-sided or have a kind of a tapered root form to themselves to better parallel the deeper insertions in some of these canals. We are also using resin-bonded systems to secure these posts, and again, gaining some sort of mechanical retention without the forces that are incumbent in a screw post or in other sort of anchoring systems. In terms of length, this is also a controversy. How long do we make the posts? According to one investigator, it should be at least equal to or slightly longer than the crown. Another investigator looks at it should not exceed 2/3 of the root length to reduce some stresses. If you keep in mind that we don't want to remove more than 4 to 5 millimeters of gutta percha in the apical extent, and then tailor your determination based on root size, diameter of the canal, and the structure that you need to support, that will guide you sufficiently. It is tragic when we see something like this. Now, did this tooth fracture because of the off-angled post? Did it fracture because it was a cast post that basically has to be hammered into the canal space? Was it too large for the native root canal space that it was placed into? All of these things are considerations in terms of answering the question, but we will never know for sure. The sad fact remains that this is the result of all of these factors placed upon this tooth. If we keep in mind that we want to place these posts in the straightest part of the canal itself, that gives us the largest margin of error. And in an upper tooth, that would be in a palatal canal. In a lower posterior tooth, that would be the distal canal. Please try not to place posts in some of the smaller canals, mesiobuccal roots of maxillary molars, mesial roots of lower molars, and I'm sure you have seen this placed before. This is a contraindication, and based on the size of these roots will lead to vertical fracture. This chart will illustrate the size diameters of two very popular post-preparation systems with their respective Gates-Glidden burrs. This is informative for people that may still be using Gates-Glidden burrs for the initial removal of the gutta percha and in their initial determination of what size drill they are going to use to prepare the post space. In the preparation of the post space, we want to initiate a small divot or a pilot for the drill to follow. If we are removing gutta percha, this is accomplished very easily. If we have a carrier, either plastic or gutta core, this may be a little bit more difficult to create, and we could use something like a preppy burr for the thermofill, or we could use a small round burr for the gutta core. Using the post drill, rotating at 2,000 RPM, we are going to penetrate the filling material to a predetermined depth that we've determined by radiographs, or more accurately, determined clinically before we obturated the selected canal. You're going to use a smooth, straight stroke and allow the drill to cavitate and remove the material. We're going to be using size verifiers once we have prepared the space. And we want to be very careful not to contaminate the etched surface not only of the canal, but also the etched surface of the selected post that we will be using. After we have etched the canal, we're going to irrigate with a sterile solution and air dry. We're going to be using the size verifier in a passive motion. Again, this is the dress rehearsal for placement of the post. We're going to etch the post hole, place the selected post into the prepared space with an even, gentle stroke, and then once the material has set that we are using to lute the post within the space itself, we twist the handle off. Let me just reiterate one of the concepts that we had from earlier on in this presentation. You should not be placing this post preparation, preparing it and placing it without the benefits of isolation. Doing so in the presence of saliva just serves to contaminate the areas that we have endeavored so carefully to keep clean. This shows the placement of the post, the middle picture, and this shows twisting of the handle to remove the excess material. A few of the more important advantages of using a passively placed, acid-etched, secured post is that we have exactly the same retention as we would have with an active screw post or a very snug fitting post, but without all the risks. We have less stress on the tooth, there's minimal tooth that has to be removed, and it enhances the retention based on the acid etching. GT post drills are unique in as much as they are longer than most post-preparation drills. They have an eccentrically tipped drill feature, which allows them to end cut the material. They are universally applicable whether you're cutting gutta percha, whether you're cutting thermofill plastic, whether you're cutting gutta core material. Any material in the use in the United States today that is being used as an obturative material can be prepared using this particular drill. There are markings on this drill, and those of you that are familiar with pro-post drill will note right away that these are longer by design to allow you to penetrate deeper than you could before with the standard pro-post drill. The length indicators allow you to maintain a monitoring of the depth so that you don't over-insert these. The color bands on the surface of the drill itself identify the diameter of this particular drill. And there are matching verifiers and posts for each particular drill. These posts are acid etched, and they are in a protective sheath to preserve the acid etching. These posts also are available as a fiber component, as the trend in restorative dentistry today is to use something that is non-metallic. So they are using fiber posts in addition to these etched posts with the same degree of retention. This investigator in 2001 examined the retention aspects, and he found that basically the more coarse the surface was, the more etched the surface was, presenting more of a surface area for retention with whatever luting agent you're using to cement this with, was better than a smooth-sided post. When we examine the GT post drill and look at the etched surface of that post compared to a non-etched surface stainless steel, you can see the differences. You can also appreciate the amount of retention and the increase in surface area available for mechanical retention when luting this into the canal space. One of the unique features with the GT post family is the knurled markings on the posts themselves, denoting different lengths of the post from the terminus to the knurled markings, as you can see here, 12, 14, and 16. This is a very unique feature. These knurled markings serve very much like the indentations on a thermofill carrier or on a gutter core carrier. They give the operator an instant feedback that they have inserted this down to the prepared depth, or that it is being inserted short. By contrast, we have the fiber posts, very similar to the stainless steel posts from the previous slide, but these are now a much softer material, and in keeping with the trend in using a very flexible, non-rigid, non-active post in the prepared space. They have exactly the same features, with the markings, the knurling, the depth measurements, the post drills that prepare the space. The only difference is in the composition of the material itself. And as I've said, there is a trend towards a more forgiving, more flexible type of post, and this is the answer to that particular requirement. So if we were to summarize the steps in post preparation, we want to make sure that we are carefully removing the obturative material completely and leaving 4 to 5 millimeters at least apically to preserve the seal. We want to create the post space with several factors in mind. We want to make sure that we're not creating one too large, one too deep, one that's deviating from the canal space, and also creating it in a safe and controlled manner. We want to tailor the size, predicated on the remaining dentin and remaining root thicknesses that we are presented with. So smaller posts in smaller canals, correspondingly larger posts in larger canals. We want to make sure that we irrigate the canal, and if you're irrigating the canal, incumbent in that after the post preparation is the fact that you've had it isolated. So we need to be sure that we are not contaminating the post space preparation with salivary contaminants. We're going to etch the canal regardless of what system we use, and we are going to prime and bond stainless steel or other metallic posts. This is not necessary for a fiber post, but we are going to prime and bond any metallic material that we're placing, and then following the luting agent applied to the canal, place both of these passively into the canal space down to the predetermined depth. Once we have allowed the post to set and the material is stable enough, we can then complete the core buildup and finalize the preparation in preparation for final impressions and fabrication of the crown, which is in fact the final story and the final step in all of this process is returning the tooth to function, sealing it coronally, allowing us to have a good stable environment for the crown to be placed, margins sealed, and preventing coronal leakage. This is the final chapter in the endodontic therapy. As you've seen previously in the presentation, there are a myriad of materials that are available to accomplish the end that we are looking for. All I ask is that you use materials that are ADA compliant, that you are comfortable using, that are user-friendly, and have the support of the manufacturer in case you encounter difficulties. Thank you for spending the time with me today. I hope you enjoyed the presentation, because I know I enjoyed presenting it to you. If I was to leave you with 3 statements of wisdom for this presentation, they would be: 1, isolation. We are endeavoring to clean these canals as best we can, but if we don't have the proper isolation, we are inoculating the canals as we are working, and this presents post-endodontic problems as we have seen. Number 2, restoring these teeth in a very timely fashion. If we have coronal leakage, we know statistically that this leads to treatment failures. So restoring these teeth in a timely fashion enhances our degree of success. And 3, posts. We have seen that they are necessary in certain cases, but please tailor the length, the size, and the use in terms of their placement within the canal system, and if you do so properly, we can expect a successful restoration with good support. I would like to thank you for attending today, and please, if you ever feel the need for a consultation or referral to an endodontist, please don't hesitate. That's what we're here for.